So welcome everyone to our Child Bright Network webinar on parent voices and evidence-based neonatal care. The webinar is brought to you by the Child Bright Network Knowledge Mobilization Clinician Hub. And our speakers today are Annie Janvier, who is professor of pediatrics and clinical ethics at Montreal University. She is a neonatologist and clinical ethicist at Saint-Justine University Health Center. Rebecca Pearce is a high school vice principal who lives in Montreal. She's a mother, an advocate, and a co-author on a number of papers discussing parental views of prematurity. She is also the chair of the Canadian Premature Babies Foundation Family Advisory Committee. Thuy Mai Luu is a pediatrician, a medical director at the CHU Saint-Justine Neonatal Follow-Up Program in Montreal. She is also the director of the Canadian Neonatal Follow-Up Network, a research network that includes 26 neonatal follow-up programs across Canada. We are very excited to have you here today to talk about parent voices and neonatal care. During the presentation, please feel free to introduce yourself in the chat room and type your questions in the chat as well. We'll answer your questions at the end of the webinar. The session today will be recorded and posted on the Child Bright Network social media accounts and website. It is now my pleasure to pass the mic to Annie, Mai, and Rebecca.
Thank you very much, Alex, for this presentation and for introducing us. I'm just going to share my slides. It's always a big honor for me to be sharing the podium, or I guess like the web camera, with these two wonderful ladies. So let's get started. So we have no conflicts to disclose, but the three of us are conflicted. And maybe as we move on with the presentation, you'll understand why. So the plan today is to discuss the limitations of traditional neonatal outcome measures. And we want to show you that parents have different ideas about what really matters. We'll also talk about incorporating stakeholder important outcomes in clinical trials, and also advocate that future clinical trials and societal resource allocation policies reflect stakeholders' priorities. So where does this start in the prematurity baby community? So we know that many fragile babies survive the NICU, but some may experience problems, especially those who are born extremely preterm. And it's really important that we measure what's the outcome of these babies. One thing that we need to remember is that neonatology is something like actually quite recent. We can say that it was probably in the late 80s, beginning of the 90s, that really survival increased due to advances in medical and obstetrical care. And since then, technologies have been progressing. We are having like new pharmacological treatment, but we don't really know all the time what's happening with those treatments because the field evolves so fast. So we need to collect data to really measure what we're doing and make sure that over the long term, these treatments, these new interventions are safe. So traditionally, what we do is we collect data on the famous three-letter words like ROP, BPD, NEC. So for those who are working in the field of perinatal medicine, these are common diagnoses. And also in follow-up, we also have our own three-letter words, NDI, that I will explain later. So as I said, it's important really to follow up the health and neurodevelopment of these babies. And to do so, we usually have a standardized follow-up assessment at 18 to 24 months. And this is not just us in Canada, but pretty much everywhere around the world in the United States, for example, the Australians also have their follow-up network. And so what we do is we do an assessment that looks at neurological status, the child development, the child hearing and visual function. And in medicine, we like to classify things. So then we decide whether the child has neurodevelopmental impairment or not. So if the child doesn't have cerebral palsy, any developmental delay, any hearing or visual impairment, we'll say, well, the child does not have NDI. Then we'll classify the child as having mild to moderate NDI, which means that the child may live with a cerebral palsy, but is able to walk around, maybe like need braces, but is quite independent in terms of moving from one place to the other. The child may have mild developmental delay, which means that the child will score 1 standard deviation below the mean and may have some hearing or visual impairment. And then we have the severe category, which are children with cerebral palsy who require some additional aids to move around, typically a wheelchair or a walker. Children that have more significant developmental delay that will for sure require some aids in terms of, occupational therapy, physical therapy, or speech and language. Children that require a hearing aid, or children who have a bilateral visual impairment. And we just have to keep in mind that this is these are definitions that were put forward by clinicians, by researchers, and it has been going around for decades. And usually what we do with those classification system is we put them in these nice figures that researchers and maybe clinicians will see all the time. So for example, this is the outcomes for babies born at less than 28 weeks in the Canadian Neonatal Follow-Up Network. So we can see that between 18 to 24 months, 17% approximately in red will have some form of significant neurodevelopmental impairment, whereas 29% will have some mild to moderate NDI. And we can see that's a paper from the American that looks at outcome at 6 to 7 years. And once again, the NDI classification is often used. In this paper, 15% of children extremely preterm displaying some form of moderate to severe NDI. So then I'll let Rebecca explain where the problem is.
Thank you, Mai. So I just want to reiterate as well that it's such a pleasure to be presenting with Annie and Mai. It's always wonderful to be here with them. So in 2009, my daughters Maren and Lily were born unexpectedly at 25 weeks and 5 days gestational age. And 1 week later, Lily developed a sudden infection that led to a series of medical complications, and she died. Maren spent 4 months and 1 week at St. Justine in Montreal, and much of her course in the NICU was very difficult. She had the same bacterial infection as Lily. She required a PDA ligation, caught a fungal infection, developed bronchopulmonary dysplasia, and spent lots of time on 100% oxygen or on a high-frequency ventilator. She was on a ventilator for a total of 7 weeks, required steroids, and came home with oxygen. And finally, a few weeks before we thought Maren might finally be discharged, she had a routine MRI, and we discovered that there was moderate damage to her cerebellum caused by a brain bleed. So I'm guessing that many of you out there, maybe not all of you, but many of you have worked with babies like Maren who are discharged from the NICU after experiencing or still with multiple medical problems, and you probably wondered how they would do and how their families might cope. Next slide, please. So we certainly had no idea what this all meant for Maren's future. So I tried to find information or research back then to help me understand how her prematurity would impact her, which we all call outcomes, and how this might impact us as a family. So as you might imagine, the research that I read in 2009 was not particularly reassuring. All the literature was really deficit-based, and the focus of the research into the outcomes of extreme prematurity then, and really still now, is on neurocognitive outcome, as Mai mentioned. So for example, blindness, deafness, cerebral palsy, the Bailey test and all its components, IQ below a certain cutoff, but also things like learning disabilities and developmental disorders like autism. So in many of these studies, children either had the condition or not, but we know that there's a huge range of functionality and impact for things like cerebral palsy, cognitive or learning difficulties, and developmental disorders. In many studies, I read and still read about outcomes that were a 3-letter word or deaf. So BPD or deaf, ROP, retinopathy of prematurity or deaf, neurodevelopmental impairment or deaf. And I still see this reported often at conferences. And this was and still is really ridiculous as a parent, because these two outcomes are clearly not similar to families. So for example, Marin's severe bronchopulmonary dysplasia diagnosis was not at all the same as if she had died. There's a quote from a recent American Life podcast that sums up my state of mind at the time: the shock of being unprepared for what has already happened. The research that I read told me that our life would never be the same again in some unknowable way, but for sure things were going to be bad. Next slide. So for years after Marin and Lily were born, I was drawn to books about families who experienced the death of a baby or who had children with disabilities, trying to make sense of my own experience and what our future might look like through the stories of others. So in 2012, I read the book Far from the Tree: Parents, Children, and the Search for Identity by Andrew Solomon, who's an American writer and PhD in psychology. For this book, Solomon interviewed the parents of exceptional children. So for example, those who live with deafness, dwarfism, autism, Down syndrome, schizophrenia, or who have serious intellectual or physical disabilities. Solomon is not equating any of these exceptions or saying that one is worse than the other, just that all these children have conditions that often make their lives and the lives of their families more challenging for various reasons. Solomon observed that while the difficulties that these families face are well known, the pleasure that they take in their children is a topic that's discussed far less. So Far from the Tree crystallized for me that the same kind of information was really missing in prematurity outcome research, and that there were two interrelated issues with the research. First, the perspectives of parents, families, and preterm individuals themselves was missing. And second, there were many things that were being measured that were not important, and things that are important that were and still are not being measured. So parental perspectives are important for several reasons. While research views prematurity as being only a deficit, and we know obviously it's very difficult, the way in which parents describe their children and put their problems, physical or developmental, in perspective is often very different from the views of healthcare professionals. Preterm babies are not just diagnoses, they're people. And what do we know about these people's potential, their abilities and successes, the happiness that they bring to their families? We know that extremely preterm individuals are more likely to have problems in school, more health and mental health issues, more social problems, but how are they actually doing on a daily basis? How do parents regard the impact of prematurity on their daily lives? Regarding what is and what is not being measured in outcome research, most of the outcome measures that have been chosen, like neurodevelopmental impairment, have been done so by doctors and scientists without taking into account what parents or families may consider important and concerns that they may have. In their 2020 paper, Outcomes from the Other Side, retired neonatologist Thuy Mai Luu and his colleagues point out that whereas we take care to develop outcome measures that researchers and clinicians consider important, it's common for parents and now individuals who are born very preterm to report back that to their minds, these are not the major issues. So in 2018, Annie invited me to be part of the Parents' Voice Project, which is a series of different studies that engage parents in redefining important outcomes following preterm birth. Next slide, please. So these studies have gone a long way towards including parent voice and also suggesting which outcome measures are missing. So here are the members of the Parents' Voice team, consisting of doctors, researchers, sociologists, and parents from Toronto, Vancouver, and Montreal. And on the following slide is a list of all of the publications from the Parents' Voice Project to date, if we would like to read more about the research, some of which I will now present. And I think Annie has actually pasted some of the references into the chat as well, in case you would like to read more about the research. So one of the questions that was explored in the Parents' Voice Project was whether parents agree with medical classifications of neurodevelopmental impairment. And the answer to this, maybe not surprisingly, is no. Parents tend to be more positive about their children, and we have data to support this. So this particular study of the Parents' Voice Project aimed to compare parental views of NDI with a medical definition used by the Canadian Neonatal Follow-up Network. Parents were asked whether they felt their child was developing normally or whether they had a mild, moderate, or serious developmental impairment. Parent responses were compared to their child's CN-Fund developmental assessment that used current NDI classifications using Cohen's kappa statistic. So the first important result to look at is in the top left-hand corner, and this is that the concordance between parent and CN-Fund response is low with a Cohen's kappa of 0.29. So if we look overall in the bottom, the first red box, 54% of children were considered to have no NDI using CN-Fund definitions, whereas 68% of parents, top right-hand corner, classified their children as having no NDI. When a child was classified as normal using CN-FUN definitions, 83% of parents agreed with this. When a child was classified as having a mild or moderate NDI by CN-FUN, 40% of parents agreed. I'm sure you see where this is going. When a child was classified as having a significant NDI by CN-FUN, only 12% of parents agreed. So when we look at agreement of parental classification, parents view their children as being less impaired than scientists do. Another question that we asked was, do parents agree that conditions that doctors call severe disability are actually severe? And again, the answer to this question is no. Parents tend to be more positive, and we have data to support this as well. So the project used vignettes to see how parents perceive the severity of disability, but without using medical terminology or diagnoses. These vignettes were developed based on classic definitions of significant or severe NDI. The survey was distributed to the parents of very preterm children nationally and internationally using a snowball sampling technique. So on the next slide, we have an example of one of the vignettes. So this describes a child with cerebral palsy, but without any visual, hearing, or intellectual problems, but without actually using these terms. And some of the vignettes also included composite outcomes. So after each particular vignette, parents were asked 2 questions. If 0 is the worst possible health and 10 is the best possible health, where do you think this child fits on a scale of 0 to 10? And does this child's case describe a severe health condition? So here are the results for both questions. The vignette that was rated by the fewest parents as representing a severe health condition involved a child with cognitive delay based on the results of the 18-month Bailey test, with 10% of parents considering this severe. The single outcome that parents rated as the most severe is a visual impairment, with almost 51% of parents rating this as a severe health condition. And the overall vignette that was rated by most parents as representing a severe health condition involved a composite outcome of cerebral palsy and a language delay. And it's interesting to note that only about 55% of parents saw this as a severe condition and still evaluated the health of a child with this composite outcome as a 6 out of 10. So the part of the Parents' Voice project that was carried out here in Montreal at Saint Justine involved exploring the perspective of parents about the health of the premature baby, the impact that prematurity has had on their lives, any informational needs they felt that they had, and any decisional regrets they may have had as well. Parental perspectives were measured using an open-ended questionnaire given in multiple formats, and the results were analyzed thematically by a multidisciplinary research team. So here are some examples of quotes from parents, and you can see that some of the responses to the open-ended questions were quite detailed. So I won't read these all to you. I do want to point out maybe a couple of them. So the top left-hand corner, speak to us about positive stories too, not only the negative and the bad that can happen. It's impossible to always live in fear. And the bottom right-hand corner, don't just speak about cerebral palsy, but about what we will have to do in a practical sense as a family. How many appointments will we have? Where? For what? What does it mean for others, the good and the bad? A diagnosis doesn't help much. What we can actually do about it helps. So when we thematically analyze parent responses, 74% of parents reported both positive and negative impacts of prematurity on their lives. The positive impacts included gratitude, a change in perspective, stronger family connections, and viewing their child as a gift or miracle. The negative impacts included stress and anxiety, a loss of family equilibrium, and concerns about their child's development. Parents also had similar decisional regrets, including wishing they had taken better care of themselves, feeling that they were responsible for their child's preterm birth, and also wishing they had been more involved as parents while their child was in the NICU. Parents view their child's health as being generally good, with parents rating their child's health as a median of 9 out of 10 when their child was 18 months old. There are family important outcomes that are not being systematically measured in research, including breathing, feeding, sleeping, medical fragility, and behavior. Parents wanted to be better prepared for their child's NICU trajectory, the role as parents of a preterm child, and also what to expect at discharge. And finally, they wanted more optimism from their medical team. So here are some of the key messages from the Parents' Voice project. Parents have a generally positive perception of their child. They see their child's preterm birth as having both positive and negative impacts, and they report themes of resilience and positive transformation that resulted from their child's birth. For parents, their child's functioning is far more important than a medical diagnosis. The NDI classifications that are used in neonatal follow-up don't necessarily correspond to the lived experience of parents. They're more pessimistic and they sometimes miss the point. And finally, many family important outcomes are not being measured, including respiratory health, eating, and sleeping behaviors. And Annie is going to discuss this a bit further. So today, Marin is 15 years old. She had an early language delay and lots of respiratory problems when she was younger. She wears glasses and has mild strabismus in one eye, has a diagnosed math learning disability, and a mild stutter. So many of these things are quantifiable, and I'm sure that they relate to neurodevelopment and her prematurity. You'll also notice that these descriptors that I used for Marin are negative. And this is certainly not how we ever think about our daughter, but this is how she would probably be viewed by many clinicians. She's also a kind, funny teenager who plays the flute and piano. She swims, figure skates, does karate, and just started indoor climbing. She likes to read and listen to Taylor Swift, and she's getting decent grades in a regular school. She's super healthy. She has friends. She's a beloved big sister. She's independent and happy and considers herself like any other teenager. Now that Marin is older, I can see how many of the findings from some of the studies that I read when she was young translate into everyday functioning. For example, her weaker working memory means she needs to study harder than many of her classmates. She's maybe a little bit less mature than some of her peers. And as a parent, I find these observations a lot more pertinent than statistics about the percentage of 25 weekers of processing speed or working memory problems. And I would think that this kind of information would be relevant for clinicians to be able to help and counsel the parents of preterm children. But how much research is out there where parents are asked to describe the functioning of their children or adolescents who were born extremely preterm? We consider Marin's outcome to be very good, but what do other parents think about how their own children are doing based on the values that are important to them? What outcomes are important to them? How do parent views align or not with the views of the medical professionals who are the ones assessing and categorizing the outcomes of preterm children? These are big, complex, but very important questions, and I appreciate people like Annie and Mai who are trying to answer these questions and change how preterm outcomes are reported.
It's a pleasure to be with you all today and to speak with Rebecca and Mai about this issue. I'm a neonatologist and a researcher on parental perspectives, and this is me in preterm labor at 23 weeks in 2005. And my own story perspective as a parent changed the way I saw things. And this is eventually one of the reasons I engaged as co-engaged in the Parent Important Outcomes Project and the Parent Voice Project. So just the words that doctors use, for example, incompetent cervix, are very special, or bed rest. And as a woman having a preterm labor for I see there's parent representatives, this is a word you should avoid. We don't tell men they have incompetent penises when they're impotent, for example. So often we add insult to injury. And during the prenatal consultation, we use NDI and we use all these three-letter words to ask parents to make life and death decisions. So I was asked to make a life and death decision for my daughter based on statistics that doctors think are important. So there's many things, I think Rebecca and Mai and what we've demonstrated, things that we measure that are not that important for parents, and things we don't measure that are important for parents. And we ask based on doctors' values that things that are important for doctors to inform parents or to ask parents to make life and death decisions. So this is a problem. Next slide. So I'll tell you the story of Violette and I'll speak about pulmonary outcomes. I know that Child Bright is really mainly focused on the brain, but the lung outcomes and the brain outcomes are associated often, generally. If you can't breathe, you don't develop very well. So this is Violette when she was born. This is what a baby looks like at 24 weeks. And she was intubated, as you can see. Next slide. And the number of intubations are not measured by doctors, and there's no study to try to decrease the number of intubations. So I'm giving you examples of things that are important that are not being measured. So Violette was intubated 3 times because she wasn't breathing enough and she had apnea. Her brain wasn't telling her to breathe. Next slide. And she had nearly died and had her 4th intubation at a month of age. Next slide. And the neonatal, for those who are in neonatology, the hospitalization has many ups and many downs. So this is one of the ups, and then a down with a complication where she needed her 5th intubation. And you'll see why the number of intubation will be important in her story. Next slide. Then she had retinopathy, which was another down. That also influences neurodevelopment, and many ups and many downs. So it was a very hard hospitalization. But she went from weighing 680 grams on this picture with the wedding ring around her, her wrist. That's the wedding ring of my husband that he lost. So we're now at wedding ring number 3. And this is how she was when she was discharged, weighing about 4 times her weight. And I often joke that thankfully we don't do that in adult medicine, but it's actually amazing that we can do that in neonatology. And according to neonatologists, and I'm part of that group, sometimes I'm a little bit shy of all our definitions and stuff. I was told, you know, Violette had a good an ICU course. I thought it was horrendous, but according to our own statistics, she didn't have a severe bleeding in her head. She had some sepsis episode and a minor neck, that's an intestinal problem, and retinopathy that was serious, but she had no bronchopulmonary dysplasia. This is the 3-letter word in purple, and BPD means oxygen need at 36 weeks. This is what we measure in neonatology. All our outcomes are based on measuring BPD, i.e. oxygen at 36 weeks, and decreasing BPD. Although she had many steroids to prevent her problem with her airway, and that decreases the oxygen use. Next slide. Then for those who don't do neonatal follow-up and who evaluate children later on, just to know that for parents, it's very stressful. Even if you know as a neonatologist why you do neonatal follow-up, it's very stressful to have your baby evaluated at 18 months to know if they're normal, mild, moderate, or severely impaired, the way we categorize it. And somehow, even if rationally it made no sense that this reflected my motherhood and how I was good as a mother, I still, neonatal follow-up, felt like we were being judged in our parental capacity, and our child was also being judged, which it's true, it's an evaluation and a judgment of how a child is able to move and several neurological outcomes. So this is us, we're neonatologists, right? We like to do things right, and we're pretty efficient. So we had a Bailey boot camp because she had to do the Bailey, have a Bailey score and do all kind of exercises. So we prepped her so she would have good scores. Next slide. So according to neonatologists, she got evaluated. This took half a day. It was kind of actually long, and she was a bit tired. And at the end, the super kind psychologist came to see us, and she was super happy to tell us, you know, that Violette was normal. And as parents, we're like, no, she's not normal. She's amazing. Like, our daughter has been doing all these things. She's gone through all this stuff. You know, she's not normal. This meant she didn't have any disability according to what doctors evaluate. But on the other hand, we knew that Violette had issues. Despite being amazing, she had ENT issues, ear, nose, and throat. She had her trachea, the tube to breathe was too small. So she has stridor and she has tugging, and it was hard for her to breathe. At every infection, it was very problematic. She had feeding problems, feeding aversion. She wasn't gaining enough weight. It was extremely difficult. She had sleeping problems. She had executive dysfunction. And honestly, if I was a parent in the Voice of Parent project and I had been asked, is your child disabled? I think I would have written mild, moderate disability, because a kid who can't breathe properly, sleep properly, and feed properly, and function properly is not a child who has no problems. There's serious problems. And because these serious problems are not measured, they're not real, to doctors. They're not counted as a problem that is part of a study. You need to have a problem identified before you do a study to try to decrease the problem. And often it's a diagnosis leads to resources, but having absolutely not identified these things as significant problems in neonatology, well, there's no resources attached. So all these functional problems that premature babies have that are not identified lead to lack of resources, lack of data, and lack of trials to make them better. So her severe ENT problems led to, at 15, needing an important tracheal reconstruction with a bone graft from her rib, 8-hour surgery, 3 ENTs working on it. And according to ENT colleagues, this is not rare in the premature population, but I had never learned this as a neonatologist. I couldn't find real articles about case series because we actually don't look for it as a problem, so it is not described. And this was probably related to the number of intubations that she had. So today Violette is now 19. She's now in nursing school. She also needs to study twice as much as others to get to the same result. And as soon as she had her trachea reconstructed, she was forced by her nasty mother to do a 5-kilometer race. You can see in the middle in the honor of her ENT doctor. And this is not to say that because my child was tagged as normal and she had many problems, life for babies at 24, 25 weeks and extremely preterm is not worth it. Is that it's important to measure the right things. So from the Voice of Parents project, we were interested to see, because doctors measure BPD as their important outcome, and we were interested to see what parents thought. And about half the parents spoke about pulmonary important outcomes, 44% of parents. Interestingly, none of the parents spoke about BPD. For them, it wasn't important to need oxygen at 36 weeks. And when parents spoke about pulmonary problems, it wasn't even associated with a diagnosis of BPD. Some parents of children without BPD reported important problems. And you can see all these problems at the right. These are problems that are important for families that are not now they're starting to be, because we've been saying this for a while, but they're not regularly measured in randomized trials, such as hospital readmissions, frequent infections, ENT problems, surgery, work of breathing, coughing, wheezing, difficulty breathing, impact on sleep, feeding and nutritional impact of breathing, limitation in activities, home oxygen, isolation of family to avoid being sick, and recommendations to avoid daycare. Next slide. So there's a harm when we measure only one problem that we focus on, that we think for doctors, when I say we, I get confused now if I'm the parent or the doctor, but there's harm in measuring the scientific community, something that the scientific community has identified as important, without asking parents. Because BPD doesn't correlate with long-term functional outcomes that are important to families necessarily. For example, there's studies of steroids to reduce BPD, and these are not correlated with long-term lung function for those that have looked at the family important outcomes. And there's other trials that show no impact on BPD, but that show an impact. Some of them have measured, for example, rehospitalization and future lung function that show that they work, but because they don't decrease BPD, we don't use these interventions. So how can we go forward? How can we measure stakeholder important outcomes, integrate them in neonatal research, and more importantly, integrate them in follow-up data? So that's your part, Mai.
Yeah, I will take over from here. So after we did the Parents' Voice project, working closely with the Canadian Premature Babies Foundation and Prima Quebec, one thing the parents said was like, this is amazing. You found, you identify these issues. Now you have to move forward and not leave it in a paper that only scientists will read and forget then about it. So we had like very simple actions that were concrete that we could do immediately. Something that parents said was like, well, when you report on deaf or NDI, it means that you judge that deaf or having a neurodevelopmental impairment is on the same scale, which doesn't make any sense. So actually now, if there are researchers asking us about deaf or NDI, we just don't give the data anymore. And we ask them to just describe what the child can do, but in a very non-judgmental way. So for example, if the child has cerebral palsy, some people were using labels like severe cerebral palsy, severe hearing loss. Now we're asking researchers to report on cerebral palsy and the gross motor function classification system without putting any label on that, or the child requires hearing aids and that's it. It's not your role to comment on the severity. And now what we're trying to do is, because we were not measuring quality of life or functioning that parents thought were really important, we are integrating these measures into a neonatal follow-up of all premature Canadian babies. So we're trying to get that integrated in the 24-26 programs across the country. And this is the work that Catherine Demers, who's on the panel here, is doing. So that's changing practices, something that people are not, doctors don't really like. But I think it's really important that we start collecting these functioning and quality of life measures, not just for research, but also to make sure that in clinic, we're really getting at what's important for families. And this is just one of the paper we wrote to really look at how we could actually measure those very important outcomes. And because there were so many, as a group, we've decided to focus with parents. They mentioned that their top priority was that we focus on quality of life and functional outcome. So what we're trying to do now is really to integrate measures of quality of life and functioning in the CN Fund. But beyond research, I think the Parents' Voice Project told us about the importance of communicating in an empathetic way with families. And what we tend to do sometimes in medicine is just to give this generic information, sometimes providing statistics that maybe don't mean very much for families. What they've asked from us is really to give personalized, but mostly practical information, and also to adapt the amount of information to what the family wants. Some parents want a lot of information and others want the big picture. And sometimes we just actually, I think as doctors, we just give a lot of information and maybe it's too much and not requested. In the NICU, and maybe Annie can talk more about it because I work in follow-up, but some parents do not want to make life and death decisions and they want recommendations. So I think it's really important to get a sense of what are the family values, where do they come from, and how we can partner to them to really provide guidance which is adapted to them and not have a one-size-fits-all type of approach. So one of the things that we like to tell is, while some parents, for example, need a lot of information, other parents just want like a lot of details or just want the big picture, whatever. So what kind of parents are you? So this is something that actually Annie taught me and that I use it very often in clinic. So some parents, other parents, what kind of parent are you? And then we can have a sense of how we should pursue our conversation. When parents tell us that they want practical information, they want to know how they can be prepared to take care of a child who has different needs, what they can do to help. They want to know also not what the children is able to do, and we tend as doctors to always focus on the deficit. Also at the same time, what I've had since the Parents' Voice Project is I'm really trying to focus on what the child can do, not just what he can do. But surprisingly, I have been accused by my colleagues in neonatology that I'm maybe too optimistic and I walk in the field of flowers all the time. But actually, I think there's a difference between being optimistic and pessimistic. Actually, I think it's important to be realistic, and it's possible to have a balance, you showing both the optimistic side, and also like the reality. But right now, what's happening in medicine is we tend to focus on the negative and pessimistic aspect. I think it's important to acknowledge that it's important to acknowledge a parent that it's normal that they have emotions and that it's hard, but they can adapt and cope. And we've heard a lot about positive transformation throughout the Parents' Voice project. And finally, I think when we counsel parents, the diagnosis sometimes doesn't mean very much. I think it's important to tell what it means, how does it look like, what's the impact on the function. So, for example, if the child has cerebral palsy, what does it mean exactly? Well, it means that, well, yes, you will need to have appointment at physical therapy. Your child will probably need to work more to be able to walk, jump, run, but we'll be there, to accompany you. So it's really important to talk about what it means in daily life. Oops, sorry, I think I did something wrong here. And Annie has been working with the parents group in the neonatology unit to work on prenatal workshops that could really help them learn about what to expect in the NICU. And now we have to work on workshops to what to expect after the NICU. And finally, what we've been moving towards is really the importance of F words when talking about neurodevelopmental disabilities. And actually, as part of the CN Fund, one of the measures we want to integrate is the About My Baby, which was developed by Dr. Rosenbaum, that really it's a questionnaire that really looks at the F words, looking at the child's fitness, functioning, participation, that includes friends, that looks also at the environmental factors such as family, and also how the child can have fun, and finally how all of these elements are important to guide the future. And so this is what we're really trying to bring clinicians to look for in their visits. So in conclusion, redefining outcomes and classification of outcome of neonatology is essential. As we said, it is important to measure outcome because neonatology always brings new treatment, new intervention. So it's really important to monitor what we're doing over the long term. But there's a way to do it to do it more appropriately than what we're currently doing. Severe categories should no longer exist. As I mentioned before, we should describe the outcome with using neutral language. We should be focusing more on function over diagnosis. We are working really hard to integrate family important outcomes in clinical trials. And also we are working on developing research methodology to really try to avoid those DEF or NDI outcomes, but still be able to consider some methodological concerns where doing such outcomes, which for parents don't make sense, but it's really hard to convince the researchers. So that's why we have to develop new methodology. So on that note, we'll end here.
Thank you so much for this powerful presentation. I think I speak for everyone here when I say that we're very grateful for the opportunity to learn from your research and also from your personal experiences. So it was really, really interesting. So if you have questions, feel free to type them in the chat or unmute yourself to ask the question. If you're not comfortable, you can keep your camera off as well. But I can start us with one question. I'm coming from the KTKM side. Oh, I see Marie-Ève, you have a question?
No, I don't. I just wanted to just give some faces for the panelists now that you've removed the slides.
Excellent. My question is about knowledge translation into practice. I'm sure you're encountering challenges and obstacles when doing so, especially in the clinical fields. Can you tell us a bit about that? What are the main ones that you encounter? And also what kind of resources you might need to facilitate the process? Do you need knowledge brokers, mediators between parents and clinicians? What kind of resources as well? Thank you.
So I think with the parents' voice, there are two things. There's the clinic and there's the research. And we think that by integrating so what we're trying to do with Catherine is to integrate parent-reported outcome measures that really looks at quality of life and functioning. So on a clinical standpoint, it's kind of hard to tell clinicians, well, it would be better if you integrated these measures because that's what parents are asking to, and they'll say, well, I'm a good doctor. Why would I need to change? So when we're suggesting to bring things, it's always like, changing a behavior is kind of difficult. And then for research, some people will not understand why we want to look at quality of life and functioning, because it's, for many researchers that we've met, these are maybe like, according to their perspective, not as solid or robust than a diagnosis. So then we have to explain how this balances with functioning, and that we're not excluding all diagnosis. I think when we talk about diagnosis, it also has to come with the functioning piece and the quality of life piece. So it's really changing the mentality, which is difficult in the research world. And for clinicians, it's changing a habit. And maybe, I'm sure the clinicians in neonatal follow-up are doing a great job, but I think we can improve. But it's always a little bit confronting when we tell them, well, maybe this parent-reported outcome measure can make you even better, because it does require additional work, it's a change of behavior.
And I can speak from the prenatal and ICU perspective. Prenatally, people are extremely pessimistic in obstetrics and neonatology about extremely preterms. So we're told in the standard of care is we meet parents and we give them a long list of everything that can go wrong. And this is not how anything else is done in medicine. There's a balanced view, and also function is discussed a lot more, and what parents can do and what families can do. So we found that prenatal workshops were very helpful to have parents in the same room, to show them pictures about skin to skin care, about the role of parents, about the function of babies, so that helps. In the NICU, where neonatologists are so used of saying, oh, you have a hemorrhage in your brain, and this means severe disability. And also speaking about diagnosis and not function. So we've published articles, and this will have to, I think it'll take years before doctors speak about function rather than outcomes, because you need to measure the function to be able to speak about the outcomes. But some things should be taught, like you don't say severe disability, you say deafness where you will have to use a cochlear implant, for example. So the function and what you can do to help the function. In research, I'm part of the group of trialists that always saw my research as like flower power cute stuff, but now they're actually changing, because when a good trialist who does randomized trials sees that he's measuring BPD and he's never finding any difference between interventions, because we've been looking at this for 50 years, and that he realizes that there's 20 things that are important, like rehospitalization, use of meds, oral aversion, that these can be measured too scientifically. And if these can be measured, maybe trials will find new interventions to decrease those. So I think it's a very complex, many places, change of culture, but also change of the first one who will do trials, but he's with us because we're doing the parent important breathing outcomes. The first one who will integrate this is a super machine. And once the Brett Manley has integrated that, people will start integrating it as a measure. So I think it's slow changes, but changes nonetheless.
Thank you, Marie-Ève.
Yes, no, I really do have a question. This is an amazing presentation. The project is great and so well aligned with my research priorities and values. My question is, have you ever measured or observed how having kind of a strength-based language has an impact on parenting or parental stress and mental health?
They've looked at, so when the studies that have been done prenatally are almost mock studies where instead of you can say a baby will survive or die, you can say he'll be impaired or non-impaired. You can use deaf, non-deaf. So there's use of positive language, survival, negative language, death. And you can see that just presenting that, this was like a fake study. It was real parents, but they were told, if you were told this, would you decide to resuscitate your baby? Presenting the positive language, twice as much would resuscitate their baby, but it was the same information given. So if you say 50% survival and 50% death, it's the same thing. Then there's been literature, I think you may be, you may know about what kids can do as opposed can't do in the trisomy 21 literature, the Down syndrome. It's wonderful literature of how parents respond psychologically and respond decision-wise. And in the prenatal literature about Down syndrome, parents really want rather know what the kids can do than what they can't do. So a deficit-based description of the long list of what won't work is not the way to go. In neonatology, we've not done that. And now in my studies, I don't measure psychological impacts much because parents in the NICU don't have a normal cycle. I mean, it's hard. So if you ask them, is it hard or is it harder? But if you ask them other questions, why do you like this language better than that one and why? And how does that make you feel? And does it help you be a parent? And because quantitative psychological scores are rarely changed in different approaches, but parents' reports of what is important to them in interviews will be very different.
Thank you.
Okay, I see. I don't know if you have any more questions. So I want to thank Annie, Rebecca, and Mai very much for this wonderful presentation. The recording will be available on our website shortly. I'm adding our evaluation form to the chat if you can take a moment to complete it. And yes, thank you for joining us today and have a wonderful weekend.
Thank you.
Thank you.